Thank you so much, Nabila. I really appreciate being here. Good morning, everyone. Thank you to the organizers to organize this session and invite different stakeholders from different streams. So, as I will soon discuss, health security and weapons governance actually have a lot in common, But I believe health security offers some lessons to weapons governance and vice versa, and this is what I will talk about today. So, it is no secret that epidemics are a global concern. Last century, we have seen many pandemics and epidemics, and cost of these epidemics is extremely high. And this is not just because of the lives lost, but also because of the impact on private sector, the socioeconomic cost, lost labor productivity, and so on. And like other weapons of mass destruction, effect of epidemics are high impact and can be felt beyond the borders, whether man-made or natural. And this is why health security or protection of human and animal health from infectious diseases and other public health emergencies is extremely crucial. To quote Jens Orbach a bit earlier, man is a catastrophic risk. Anthropogenic factors are increasing the risk of outbreaks over the last decades. In fact, between 2011 and 2017, there have been over 1,000 epidemics in 172 countries. Now, a lot of these factors include things like climate change, urbanization, lack of disease surveillance and response, but I want to focus on conflict today. War and conflict has an indomitable link to epidemics. More people have actually died during the 1918 flu epidemic than in World War I and World War II, for that matter. So how does conflict lead to epidemics? It can lead to epidemics by interrupting routine immunization services, leading to forced displacement. Last year, we saw that the number of people who are forcibly displaced is at 70 million. At the same time, shortages can be another reason. For the 2 billion people that are living in fragile and conflict-affected states, this is real, and this is significant because a lot of fragile conflict-affected states actually overlap with global hotspots for emerging infectious diseases. By 2030, 50% of the world's population would be living in fragile conflict-affected states. At the same time, epidemics can also lead to conflict or used as tools of war and have geopolitical ramifications. And we've seen that in the past, when smallpox blankets were distributed to Native Americans during the Fort Pitt siege, or when during the 19th century cholera epidemic in Europe, there were riots. So, as I like to say, there are many examples of conflict leading to epidemics, from Yemen, where 1.2 million people suffered from cholera epidemic due to war and famine, to polio in Syria, Nigeria, Pakistan, and measles in DRC. And as I call this the new normal, unfortunately. Because as insecurity and violent conflicts increase, which they have increased since 2010, more than at any point in the last 30 years, we will see more regional spillovers, and epidemics will increasingly occur in insecure regions. And nowhere is that more seen recently than the DRC Ebola 10 epidemic. Now, in DRC, we have been in the 10th epidemic, we haven't been able to contain it, despite having swift mobilization of initial funds. Why is that? Because of insecurity. There have been 237 attacks in a matter of 8 months. Attacks on first responders, attacks on Ebola treatment centers, leading to multiple breaks in vaccination campaigns, as well as contact tracing, which you can see on the slide. So the top graph shows the insecurity incidents, and the bottom one shows how that affected contact tracing, which is crucial to control Ebola. Furthermore, limited coordination with the humanitarian sector and weak community engagement, lack of trust in government, and has also led to a very slow response. As a result, today, the DRC EVD-10 outbreak poses a security risk to the neighboring countries due to porous borders. Now, given the challenges we are facing in global health security, what governance tools exist? There are a few, the most important one being what I call the international health regulations, which initially, in its initial form, only covered 6 diseases. But post-SARS epidemic, it was reformed to broaden the scope to an all-hazards approach, which covered risks from people, vectors, goods, environment, including chemicals and radionuclear disasters, making these regulations agile. As of today, 194 countries have signed on to IHR. And this is interesting because these regulations bind these countries to meet the minimum criteria needed for core IHR capacities such as surveillance, human resources, risk communication, to avert public health emergencies of international concern. Other relevant treaties include the PIP framework, or the Pandemic Influenza Preparedness Framework, which is a non-treaty-based agreement that came to be after Indonesia refused to share avian influenza samples for vaccines. Now, this framework set commitments for virus sharing and benefit sharing once a vaccine is developed. And there is also the global health security agenda led by United States, and of course, not to mention Biological Weapons Convention, the World Trade Organization sanitary and phytosanitary measures, and so on, which also have public health implications. So what are the really unique aspects of global health security governance? For one, very similar to weapons governance, it's very top-down. And unlike many other fields, much apart from the international health regulations, much of the global health governance revolves around soft laws, which are easier to negotiate than treaties, but very difficult to ensure compliance to. For that matter, even for IHR, compliance proves to be tricky. So, as Nabila mentioned, I'm a public health security specialist. So I'm going to talk about some of the lessons from the 2014 Ebola outbreak. The 2014 West Africa Ebola outbreak highlighted various challenges in coordination, lack of accountability and compliance with international health regulations, monitoring and evaluation, and so on. And since then, international community has taken some measures. I'm not going to say them all, given the short time, but I'd like to mention a few, such as the Strategic Response Plan and the National Action Plan for Health Security, which brings together different stakeholders and donors to work with the countries to ensure that they are able to reach and cost how to reach international health regulation compliance. At the same time, countries need to be in driver's seat. We cannot make it completely top-down. And one way to do that is by engaging regional players and setting up multi-sectoral One Health platforms with different sectors. And this has been done in West Africa in a program called REDICE that's funded by the World Bank, where they have actually, West African Health Organization coordinates and brings together countries. Monitoring and evaluation is another area where joint external evaluation, which was launched a few years ago, has enabled greater monitoring and evaluation. Before the 2014 Ebola outbreak, only 30% of countries were reporting on their IHR compliance, and that was self-reporting. The JEE makes sure that it's externally evaluated. Not to mention the role of private sector. I think private sector can play a great role, and in more recent years, since 2014 outbreak, we have seen initiatives such as Private Sector Roundtable and World Economic Forum Epidemic Readiness Accelerator that brings together private sector for emergency response. But at the same time, there are challenges that remain. For one, biosecurity and biosafety in the era of pandemic research and Global Virome Project, which, if you don't know about this, it's really cool. It's a $350 million project led by US and China that is developing an atlas of emerging viruses. But at the same time, let's remind ourselves that any technology that can be used for good, in absence of good governance, can be used for bad. And at the same time, the number of labs that are doing research, sequencing, now today we can synthesize viruses in lab. So we have to make sure we keep that into mind. Not every country needs a biosafety lab level 3 where you can research pandemic causing organisms. You just need good lab networks. At the same time, Harjeet before me talked about bottoms-up approach. Global health security has been very top-down. And one way to mobilize leadership to mobilize countries to actually care about IHR compliance is to combine the top-down approach with bottoms-up approach. By engaging private sector, communities, civil societies, that's one way to put pressure on leaders. At the same time, the accountability for reporting and compliance with IHR is a challenge. There are no built-in accountability and enforcement measures. One way that, in my opinion, we could do is maybe name and shame. That's one way. After the 2014 Ebola outbreak, 56 countries levied trade restrictions on the Ebola-affected countries, despite WHO's recommendations not to do so. This impacted the response significantly. I talked about joint external evaluation of how countries are progressing towards IHR. That is also voluntary. And while we have initiatives such as the JEE Alliance that has improved countries doing JEE, only 85 countries have done that so far. Even countries such as India, my own country, has not had a JEE yet. Earlier, I think Rakesh Sood brought up the point of sovereignty versus global action. This, again, remains an issue in global health security as well, where, for example, during the 2009 pandemic influenza outbreak, in Australia, private sector companies were told not to export vaccines until domestic demands are met. At the same time, we need international agreements for specimen transport, for medical countermeasures, especially in insecure areas, because that's a challenge. It takes a long time for those material transfer agreements to happen. Those agreements would help global health security governance. Last but not the least, dispute resolution is key. And that is a challenge we also face in IHR as well as global health security governance. So lastly, one thing I want you to take away from my talk is that strategic action by mobilizing communities, mobilizing private sector with a bottoms-up approach combined with a top-down approach, and a combination of incentives, enforcement, along with collaborative readiness is the key to global health security and prevention from infectious disease threats. Thank you so much for your time.